For instance, the medical student might be introduced in her pharmacology course to the notion of drugs as transmitters of chemically coded information. From a study guide distributed in our medical pharmacology class some years ago, one reads this quote: "Drugs represent chemically coded information. The effect of most drugs is the result of their interaction with macromolecular components of cells. Note that the macromolecular components are the receptors. There are two different kinds of receptors. A. Drug receptors, molecules in the cell for some other reason but which bind the drug. B. Receptors for endogenous regulatory ligands, molecules which normally act as receptors. They have two distinct functions: 1. A binding function, and 2. An effector, active domain." In this excerpt, the chosen root metaphor is coded information. It provides the subcategories in terms of which the finer details of clinical possibility are grasped, categories such as regulatory ligands, or binding function, or action domain. Close quote. In this way, a logically coherent construct emerges, in terms of the categories of the applied root metaphor of coded information. Using the Socratic method of teaching, an attending physician might ask a medical student a leading question in terms of this coded information root metaphor. For instance, regarding the administration of digoxin to a patient with heart failure, the attending physician might ask a student, "What chemically coded message does digoxin deliver to the muscles of the heart to make it pump better?" This question requires the student to conceive of the action of this drug in terms of delivered chemically coded information. It thereby provides the metaphorical causality with which to grasp and actualize the intended possibility. To this student, the terms of chemically coded information will not appear as a metaphorical grasp of clinical possibility. They will appear as the grasped possibilities themselves. They will appear given as the products of objective discovery. A critically thinking medical student might object to the terms of the posed question. For instance, she might protest that she was taught by her favorite pharmacology professor that drugs are in fact keys that unlock inherent chemical processes, not carriers of chemically coded information. This is ultimately a disagreement about the choice of metaphor, not about the goal of the medical decision. The goal is not to find the right metaphor. It is not even to avoid metaphor. Instead, the goal is to use metaphor for the grasp and actualization of human possibility as it is apprehended in the clinical situation. Though the specific metaphor with which one grasps possibility is not given, the possibility that one apprehends is given to consciousness. The metaphor, on the other hand, is an existential choice, driven by the user's perspective with regard to the intended possibility and the trajectory of intention regarding its actualization. The creative use of the physical sciences. Medicine is practiced and taught in terms of the physical sciences. Thereby, medicine appears essentially to be a project of the physical sciences. However, medicine is not itself a physical science. Rather, it essentially is a social science that uses the physical sciences creatively for its deeper humanistic agenda, that is, the actualization of human possibility. The notion of a creative use of the physical sciences is counterintuitive to the modern ear. This is because the physical sciences function by appearing as the ends in themselves in any project to which they are applied. So, for instance, when medicine is practiced as anatomy or physiology or pharmacology, it appears to be simply a project and product of anatomy, physiology, or pharmacology. But, as every healthcare worker knows, medicine ceases to be medicine if its tools are used for their objective ends only, rather than in the service of its deeper human call. This agenda, revealed in our analysis of the structure of medical decision-making, is the perception of human possibility for the sake of its actualization. Despite this creative activity, the popular notion of medical decision-making is that of a straightforward logical proof, with necessary conclusions derived from given data and their inherent logical connections. This is formalized as evidence-based medicine. The evidence-based decision appears to emerge from rigorous observation alone, that is, as a passive act. There is no role in this conception for an active, creative initiative or synthetic response to a more deeply perceived domain of possibility. The medical decision as a creative response. The physicist David Bohm stressed that fundamental reality is an unbroken wholeness, an inseparable quantum interconnectedness, that we artificially carve up as theoretical objects for our subjective need. In possibility theory, we have proposed a way to refer to this background wholeness as direct apprehension of the domain of possibility. The medical decision emerges as a creative response to this domain of possibility in the milieu of the doctor-patient relationship. This subjective act determines what will count as clinical data and the terms of measurement and intervention. It is not a passive act. For example, consider a patient with Alzheimer-type dementia, who can be expected to manifest progressive decline in cognitive function over time. At each point in his follow-up visits, this change will warrant a modification of the treatment plan, driven by his subjective needs relative to his decline. The need for comfort and dignity, though always present, will take different forms over his course. His requirements for physical and intellectual stimulation, though always present, will evolve. This will influence the kind and the timing of medicines and other arrangements, such as the location and structure of his supportive environment, and the prognosis that is given to the family. The mere anatomic and physiologic changes in the brain of the patient with Alzheimer's dementia, in isolation from their subjective meaning, will render no effective clinical decision points for the family. These objective changes become disease only by virtue of their subjective meaning to the patient and family. The anthropic conditions of knowing, the terms that emerge to grasp human possibility, do not arise only from our trajectory of intention regarding the patient. They are formed also by the need to grasp possibility as an object for the subject. That is, the object must take on anthropic characteristics. An example of this is the notion in molecular biology of histocompatibility. In the mid-century, based on experiments with tumors transplanted into mice, a set of proteins on cell surfaces was found to be associated with immunologic rejection of the transplanted cancer cells. Therefore, these cell surface proteins were called histocompatibility proteins, reflecting their phenotypically conceived function. The formulation of a genetic origin for these proteins began by positing the existence of a histocompatibility locus in the genome, where these proteins are encoded. Eventually, this genetic locus was found to reside on chromosome 6. The notion of tissue compatibility is transparently anthropic. It derives historically from the narrow focus of these initial laboratory experiments. Genes do not come with such names assigned to them. The metaphorical origin of the name is the contribution of the mind to the formed object. It reflects human possibility as it is perceived by the clinician. Just as in the case of Socrates' definition of the sophist as an angler, it represents a trajectory of intention regarding human possibility, providing the manner in which clinical data are defined, measured, and causally connected in theory. This is not to say that genetic loci do not exist. It is to say that their existence, as loci, is a function of the user's anthropic perspective for the purpose of the subject-object interaction whereby human possibility is grasped and actualized. Nevertheless, this histocompatibility locus and its products will appear to the clinician not as a metaphorical grasp of possibility, but as the grasped possibility itself. Nature will appear to have provided a histocompatibility locus that we merely appropriate. The anthropic nature of these terms persists in the metaphorical categories with which finer details of the intended human possibility are grasped. So, for instance, in treating a viral infection, the clinician may conceive of a patient's white blood cells as recognizing a virus as foreign. As a medical text says, one anticipates finding signaling molecules, called cytokines, helping branches of the immune system to talk to each other and respond to threats. The formulation thereby emerges with a coherence in terms of the categories of tissue compatibility and within the broader metaphorical context of the interactive molecules of molecular biology. Subjective versus objective knowledge. The nature of medical decision-making is of singular interest to intellectual history because of this interdependence of subjective and objective thought. This question of the nature of the interdependence of objective and subjective knowing, and its meaning for the human enterprise, is central to intellectual history. This manifests, for instance, as questions of faith versus reason, of the social and ethical consequences of material reductionism and mechanization, of the natural evolution of consciousness and the source of its value judgments, of the ontological status of mathematics, of the notion of the divine in a material world, even of democracy and individual freedom. For all these things, the creative origins of objective thought in medicine can be a paradigm. Let us pause briefly, therefore, to clarify what we mean by subjective versus objective knowledge. By subjective knowledge, we mean the non-reflective familiarity fostered through association with phenomena. By objective knowledge, on the other hand, we mean the data and their logical relations that emerge from metaphor-laden theories that are applied to this subjective impression. A simple illustration is our knowledge of Aunt Bessie. By subjective impression, we mean the way in which one knows Aunt Bessie personally, such as familiarity with her face, her voice, her gait as seen from a distance, and her personal predilections, and so the kind of interaction that one anticipates having with her when she arrives at the airport tomorrow for a visit. This subjective knowledge of Aunt Bessie is non-reflective. It does not require reduction to data or measurement. Nevertheless, such knowledge is a deep well of reserve that characterizes all areas of human cognition of any consequence. Even when knowledge is reduced to data for specific purposes, it originates from this well of familiarity. This corresponds to the direct apprehension of possibility that characterizes the milieu of the doctor-patient relationship. Conversely, by objective knowledge of Aunt Bessie, we mean a description of her that might be given to someone who has never met her, but who must recognize her to pick her up tomorrow from the airport. Unlike the familiarity of subjective impression, this objective knowledge of Aunt Bessie is theory-laden. It is characterized by a reduction to data and their explicit logical relations as derived from terms of theory, such as body habitus, or hair color, or personality type, that give structure to what is experienced. This corresponds to evidence-based decision-making in medicine. This objective knowledge empowers action. It provides the terms of causality and tools of actualization. It makes it possible for one to find Aunt Bessie, even if one never has met her. For this reason, objective knowledge is the more auspicious form of knowledge. It often is referred to as knowledge itself because of its venerated status. Objective knowledge is limited by the boundaries of the metaphors upon which its theories and data are based. It does not manifest as a deep source, as does subjective knowledge in response to perception of open-ended possibility. If one identifies Aunt Bessie from a distance, based purely on objective knowledge, this must be an act of cognition different in character from the recognition of Aunt Bessie by a person who knows her. And it does not have the capacity to self-correct on its own terms, for instance if one brings home the wrong person from the airport. Taking this as our distinction between subjective and objective knowledge, we note that every area of intellectual activity involves both subjective and objective elements, commingled in peculiar ways that reflect the needs of each domain of cognitive activity. Every cognitive enterprise renders more or less weight to one element or to the other. So, for instance, in the arts or in psychology, one renders more weight to subjective impression, whereas in architecture or in physics, one gives preference to the objective form of thought. But this relative weight is notoriously not the case in medicine. In medicine, there is no preferential weight given to the subjective or the objective form of thought. Instead, the subjective and the objective elements act with equal weight and in equal deference to each other. For instance, a patient who presents to her doctor with rheumatoid arthritis might be found to have certain objective findings, such as a measurable degree of tissue inflammation that is determined by lab measurement, or of bony joint degeneration that is apparent on X-ray. But the significance of these objective measurements, the feature that makes them disease, is their subjective meaning for the patient. Objective changes in lab results or X-ray findings on their own have no meaning or relevance to the medical decision without this subjective impression. The human body is replete with variations from the norm that do not rise to the designation of disease, just because of the absence of this subjective determinant. This subjective input is communicated in terms of the patient's symptoms, such as joint pain, or in terms of relevance to her life, such as how her symptoms affect performance at work, or her ability to care for herself, or to make life plans. The clinician never can turn away from this well of subjective knowledge to a consideration of objective measurements in isolation, because symptoms, as the well of direct apprehension of human possibility, are the elements that give meaning to objective changes as disease. Objective data themselves are limited by the metaphorical boundaries of the theory from which they are derived. Subjective input from the patient often will require more from the physician than these finite parameters permit, but the doctor also cannot turn away from objective knowledge and to subjective impression in isolation. For only with these objective terms can the clinician do something for the patient. That is, only through the resulting subject-object interaction can the possibility perceived in the doctor-patient relationship be actualized. So, the physician must learn to accommodate both of these sources of knowledge, and, at the same time, reading objective test results must be accompanied by empathy for the patient. The doctor must know rheumatoid arthritis in the way that one knows Aunt Bessie. The hazard of data as ends in themselves. The codification of medical data has contributed to their appearance as ends in themselves in the decision-making process. Therein they have lost connection to the broader cosmic domain that renders to them clinical meaning. An example of this is the ICD code set, International Statistical Classification of Diseases, that lists all currently used diagnostic and treatment terms, along with distinguishing numerical code. So, for instance, the diagnosis called viral gastroenteritis has the code A08, and the diagnosis called dysentery has the code A09. This codification, that has its origin as a tool of billing, assumes on an unwarranted role in clinical decision-making. Diagnoses come into being for the sake of the subject-object, whereby possibility is grasped and actualized. As objects for the subject, therefore, these metaphorical products must be free to evolve through engagement with possibility. But codification introduces stagnation into an object, as the numerical code cannot serve the same function as the metaphor. The resulting natural evolution of diagnostic terms is aborted if a diagnosis is treated as a codified end in itself. For example, in the paradigm shift to molecular biology, one must be free to ask regarding diabetes what it really is in terms of molecular biology. This question does not occur if diabetes can be nothing but itself, codified as E. One is not free to deconstruct the number, as one can a theoretical entity, in the service of a newly emerging paradigm. Similarly, the illness called peptic ulcer disease was once thought to be an endocrine disease, caused by overproduction of stomach acid. It now is known to be an infectious disease in most cases, caused by the bacterium Helicobacter pylori that invades the bowel wall. What if the parameters of codification had confined peptic ulcer disease to a category of endocrine disease? Similarly, it has been thought that the neurologic system of the body is physiologically isolated from the immunologic system. This is an artifact of their metaphorically distinct formulations. For example, it is seen that rheumatoid arthritis, a disease of the immune system, has nothing to do with the nervous system. But it has been demonstrated that stimulation of the vagus nerve somehow centrally blocks inflammation in the spleen, the organ where the immunologic system is mediated. To explore this anomaly fully, one must appreciate that the physiologic categories, as they are defined, are provisional. One must be free from the implied given nature of these categories, so that one might envision new physiologic categories that, if necessary, subsume what we now call the neurologic and the immunologic systems. Consider the distinct but clinically similar diseases, viral gastroenteritis and bacterial dysentery, codified respectively as A08 and A09. Each is characterized by diarrhea, dehydration, fever, rash, and confusion. Imagine a medical student who is directed by her attending to evaluate an elderly woman in the emergency room who presents with the symptoms of diarrhea, dehydration, fever, and confusion. After evaluating this patient, the student might turn to her computer for diagnostic assistance. There she might discover that the disorder of viral gastroenteritis presents as diarrhea, dehydration, fever, and confusion.